Welcome to today's VA Medical Center's webinar on general primary care services in the women's clinic. That's going to be our topic. And today's special topic is going to be navigating menopause and beyond. We are honored to have two distinguished subject matter experts with us. First, we have Dr. Nicole Armitage, the Women Clinics, the Women Veterans Program Manager at the Dayton VA Medical Center. Dr. Armitage brings over 30 years of experience as a women's health nurse practitioner. A retired U.S. Air Force veteran, she served for 23 years as a nurse, scientist, and practitioner, providing care to thousands of military women. Dr. Armitage is a leader in delivering more care to the growing population of women veterans within the Dayton VA healthcare system. Joining her is Kelly Welsh, a dual board certified family nurse practitioner and midwife who serves as the Women's Health Medical Director at the Dayton VA. With over 15 years of experience in women's health, including several years as a midwife, Kelly is dedicated to providing holistic care. She offers a wide range of primary and gynecological, excuse me, uh, gynecological services, advocating passionately for the best possible care for our women veterans. And I'm Gregory Tucker, your host for the evening, public affairs specialist and proud U.S. Navy veteran. So we're going to get things off with our subject matter experts. Welcome to the show, ladies. And we're going to start things off with first question we just got, and that is for Kelly. As a midwife and nurse practitioner, what holistic care options do you offer that can help me manage my overall health and well-being? This is presented by Janet.
Well, hi, Janet. Thanks for the question. So because I'm here and I'm serving women veterans in a primary care setting in the women's clinic, we are serving patients, those of us who are women's health primary care providers, we can serve anything and everything, any medical condition, serving the whole woman. And then if you need gynecological care, we also have that as well here. So any of the birth control options, procedures, if you needed postmenopausal care, if you needed biopsies, if you had an abnormal pap smear. So we offer all of those here at the Women's Center. So when you come to visit us and any of our providers here, we're going to talk to you about holistic health in general, or whole health. We actually have services for that as well. Tonight's topic is going to focus on menopausal care and the holistic way that we provide care with that. But really, generally, with any medical condition, we're going to talk about the whole body, the whole health, things like exercise and nutrition and what kinds of supplements and what other lifestyle measures can you do to really help in that way. So hopefully that answers just kind of generally what we would do here in the women's clinic.
Okay. And I somewhat jumped the gun because we do have some slides to give you a little bit more background as far as regarding these women's health program. And Dr. Armitage, if you care to take it away.
All right, well, thank you so much for that wonderful introduction, and I'm so glad to see that questions are flowing already. I would like to just take a couple moments to talk about the women veteran population in general and some healthcare services in general that we have at the Dayton VA. So next slide. So as you can see by this slide, this is the total number of women veterans who are enrolled to the VA across the country. So you can see in the year 2000, we had 159,000 women veterans enrolled. And by 2015, that was all the way up to almost triple that at 439,000. And then in 2024, we have quadrupled that number since the year 2000 at 689,000 women who are enrolled. And in fact, it's the fastest growing population. And we're going to continue to see more and more women veterans as time goes on. And this is just a snapshot of women veterans enrolled at the Dayton VA. So we have over 6,000 women who receive care at the Dayton VA and almost 4,400 women who are actively enrolled into primary care with the primary care provider. And of those, about 2,200 are enrolled in our women's health clinic. And we are seeing a growth of about 200 more women each year. And currently in Dayton, the women make up about 13.3% of the total population. In fact, that we're growing about 3 times as much as the male veterans. And you can see on the slide, we recently renamed our clinic after the Lieutenant Colonel Charity Adams Early. And she was, for those who don't know, she was one of the first, she was actually the first Black woman who was promoted so served as an officer and actually got promoted to Lieutenant Colonel in 1945. She served in World War II and led the only all-Black female battalion who was deployed overseas to Europe. And she later moved to Dayton and was a prominent community member. So we were thrilled to rename the clinic after that. That's just a little tidbit. Now moving on to some services that we have for women veterans here at Dayton VA. So what we have in-house at the Dayton VA is as Nurse Practitioner Welsh already mentioned, we have well woman services, preventive exams to include cervical cancer screening and osteoporosis screening, contraceptive services and management, menopause care, GYN specialty care. Comprehensive mental health. One thing great about the VA is we have very robust mental health care. You can't find the equal in the community. And we have a whole health coach who is dedicated to women veterans for Women's Health Whole Health. And we have a women's health chaplain who holds spiritual care groups for women veterans specifically. And then some other services that we don't do in-house at the VA, but we partner with our community partners to provide those services in the community, and they are covered benefits by the VA. And one is breast cancer screening or mammograms, maternity care services. So we don't do OB care inside the VA. However, we do have a maternity care coordinator who stays in contact with our pregnant veterans throughout their pregnancy and 1 year postpartum, and can even provide things like breast pumps and nursing bras, and it's actually a really wonderful benefit. And infertility evaluation and treatment that we work with our community partners as well. And now I'm going to go ahead and turn it over to our main guest speaker, NP Kelly Welsh. Thank you.
So we're going to talk a little bit. This is, really the basics of moving into menopause. How does that happen? What are some of the side effects that we have? Some of the symptomatology, just really, and kind of basic and holistic, but I want you to know that you can come see your clinician, you can come see me, just to kind of talk on an individualized matter on these things as well, because it's different for everybody. So let's talk a little bit about menopause. So first, before menopause, what happens? It's something called perimenopause. I see a lot of patients come in. This is the time period. It can last anywhere from 2 to 10 years. The average length is 4 years. And this just simply means the interval that happens right before we are actually menopausal. So it is prior to complete cessation of ovarian function. And then moving into menopause, its definition is just a place in time, just a day. What that means is you're dealing with the perimenopausal symptoms, and what you might see in perimenopause is these really irregular cycles. Sometimes you'll see 2 periods a month. Patients sometimes will see, skipping several months. So what happens is as you move towards menopause, you're going to start spreading out that length of time where you ovulate and where you have a period. When you get to 12 whole months without a period, that is considered menopause right there in time. Everything after that is considered postmenopausal. The average age is 51, but we see it anywhere between 45 and 55 is kind of the average ages for that. But again, this is very individualized. Now let's say, and just real quick, I want to touch on this in the postmenopausal period. Let's say you get 12 months, 13 months, 14 months with no period, and then you have a period. We need to talk about that. We need to look at that as to why, work that up. So once you reach that 12 months, you are menopausal. You get to 10 months, 11 months, and you have a period, it starts all over to a whole 12 months again. Next slide, please. And I touched on this too. Perimenopausal symptoms are wide fluctuation in your periods and hence wide fluctuation in your hormones. There isn't actually a test that will tell us, hey, are you perimenopausal or are you not? We treat on symptoms. So when you come in, talk about how you're feeling. There isn't, because we have such a wide fluctuation of hormones during that time, there isn't a known or evidence-based panel that can tell us, hey, you're in perimenopause, but we can know based on what the symptoms you're having. Obviously the irregular periods we talked about, the mood swings, irritability. Some women, not all, will start with the hot flashes and night sweats in this period of time. And that's just because as we go through menopause, the reason we go through perimenopause and menopause is our estrogen is depleting, it's decreasing, and so it's causing some of these symptoms. And therefore, your lining is not building up each month, and so there's nothing to shed there. So some hot flashes, some sleep disturbances. Next slide, please. And then menopausal signs and symptoms are, in most cases, hot flashes, night sweats. So if you didn't have them in perimenopause, the chances of you having them in menopause are greater. You can get some vaginal dryness. Interesting that joint aches and pains. I see lots of patients who come in their 40s and their images look normal. They don't have any osteoarthritis, but they have multiple joint aches and pains. Not in all cases, but sometimes that can just be estrogen depletion and menopause occurring. Decreasing energy, brain fog, bone loss. What I mean by that is, you can have low bone loss or osteopenia, and then osteoporosis is when you've really lost a lot of your bone. So with estrogen depletion, that can happen, and we can get some osteopenia and some osteoporosis. You can also get increase in visceral fat. And what I mean by that is that's the fat that is around your organs. It's harder on our bodies. So the visceral fat is not, it can happen when we get into menopause. And actually menopause can cause an inflammatory state. Visceral fat, sometimes we can't see, obviously you can't see that around your organs, but what you can see is women come in to see me and they've got more fat around their middle. So that is menopause at times. So that's kind of some visceral fat that's laying there around the abdomen. So if you experience that in your 40s, 50s, 60s, sometimes it's part of the menopause period as well. And then decreased sex drive or libido, painful intercourse. Those are some things that can happen as well. And next slide. And then the first thing I want to talk about is vaginal dryness. We talked about this, that can happen, but what do we do about it when it happens? So we get vaginal dryness because as we lose that estrogen, we don't have that thick layer in the vagina anymore. We start to lose, it starts to, the tissues start to thin out. We don't have that moisture there anymore, and we don't have something we call elasticity or flexibility there. And that all happens because estrogen really helps in that way. And so if you have those things going on, you can have painful intercourse, you can have dryness, you can feel like you have a urinary tract infection. You may or may not have a urinary tract infection, but you might feel urinary frequency, just the symptoms associated with it. Lubricants, obviously, you all know about lubricants. There's a lot of different brands over the counter. So with sexual intercourse, you want to use that. So if you didn't before, that would be something to trial now. If that's not enough, first line, we're going to recommend vaginal moisturizers. Now, I have a lot of women that had no idea what that is. Just like we have to moisturize our legs, our arms, and our skin that gets dry. When we go through menopause, we need to moisturize the vagina as well. You can use that 2, 3, 4 times a week. And I just put a couple of brands down here, but there's a lot. There's Replens, Luvina. You can use straight coconut oil to see if that works for you. If you can get relief from that and the painful intercourse is a bit better, great. If it's not completely resolved and you just need something else, first line, well, really first line after the moisturizers, after that regimen, we're going to try some topical vaginal estrogens. And we do provide that here at the VA. And the way that you do that is you insert that nightly. And for the first couple of weeks, you might use that several times a week until you start to feel better. And then what happens is you back off, and a lot of women after maybe a month or 6 weeks can go to a once or twice a week regimen just to kind of keep that tissue a little bit moister, and it just helps with your comfort level. Not all women need this. But if you do use vaginal estrogens, if you have these symptoms, say you don't have any hot flashes or anything else going on, you can use this topically, like we talked about, and fairly safely. You don't need, if you have a uterus, you don't need a progesterone to go with it. Next slide, please. And these are obvious. I put down some basic things for hot flashes, night sweats. You want to make sure you have a fan in your room. You can use, there's lots of products out there. There's pillows and blankets and different things that can provide some coolness to you. Exercise is crucially important. And again, there are studies and research behind a lot of these things that are listed here. Meditation, mindfulness, self-care, essentially. There is some research behind yoga, even acupuncture. Now, it might not stop the hot flash from occurring, but research has shown that it can show the intensity can get a little bit better. So you might still have them, but they might just be a little bit better. Cognitive behavioral therapy, and then finally, menopausal hormone treatment. Next slide, please. And I've listed some herbal therapies. Now, I will preface this with, these are not under the regulation of the FDA. There is some research behind it, but they're not FDA approved. So you have to be careful with some of these. So our isoflavones like soybeans, flax seeds, lentils, they sort of mimic estrogen. So they act like estrogen in the body. So for some women, just taking in some of those can really help your hot flashes. Same thing for red clover extract. Black cohosh, there's a lot of mixed reviews on it. So I've just put it down here just to say I wouldn't recommend it just because some of the studies are showing liver issues. Evening primrose oil and vitamin E do have some pretty good research behind them. So not everybody can take hormone replacement therapy. So see, these are some of the other things that you can trial when you're going through a hot flash. Next slide. Yes, we can get sleep disturbances, that is for sure. And I would say the number one reason we get sleep disturbances with menopause is from the night sweat. So that thermoregulation in our body that just it's dysfunctional at this period of time that just can keep us up at night. So these are just regular sleep practices that are good for all of us. You want to make sure you go to bed at the same time every night. You want to make sure that you're getting up at the same time every morning. And I know you've heard before, but turning off the TVs, the phones, the computers about 1 to 2 hours before you go to bed can really help and help us fall asleep, help us stay asleep. Alcohol is kind of a hot topic. Alcohol, just in general, can deter us from sleep, but even more so in the menopausal period. So sometimes even eliminating it completely can really help a lot of people. Or at least if you're going to partake, I wouldn't do that right before bed because it might keep you up all night. And obviously, again, keeping your room temperature cool or to your liking. Melatonin is something that could help, and you can talk to one of us about that. You can get that over the counter, but we can also talk to you about that as well. Magnesium can help as well, and we can kind of go over that when you come in to see us too. Next slide, please. So mood can be affected by menopause as well. Counseling is a big option, and I know Nicole had talked about that we have really, really good mental health or behavioral health services here. We have counseling, we have whole health, we have coaching. We can talk to you about exercise and meditation and yoga and just self-care in general. We have a whole department that is just focused on whole health. And I know that sounds like, well, is that really a treatment for menopause? It actually is, because that's kind of the foundation, the basis. Now, some people are going to need more, but just getting that, really good exercise in at least 150 minutes a week. That's kind of your good basis there. SSRIs, basically what that means is just antidepressants. So antidepressants can really help in the menopausal world as well, in conjunction with counseling. And then I might speak about this later, but if it's just mood related and you're not having any hot flashes or anything like that, this is what I would stick with your antidepressant, your counseling. But even if let's say you have mood issues, agitation, irritability, and you also have hot flashes, research has shown both an SSRI or an antidepressant along with hormone replacement therapy in combination could really, really help with the mood aspect here. St. John's wort, that's something, again, St. John's wort and ginseng came up with supplements that can help with mood, but again, they're not FDA related, FDA looked at, so we have to be, we can talk about those things. They aren't provided services here because they're over the counter, but we can certainly talk to you about some of these adjunct therapies that might be able to help in your individualized scenario. Next slide, please. So, menopausal hormone therapy. So we already talked about the vaginal estrogens. For treatment of failed moisturizers, basically, if you have, the way hormone replacement therapy works is if you have a uterus, you have to have both an estrogen and a progesterone. Because if you think about it, the estrogen is what would be causing you to build up a lining. So remember, if your estrogen is depleted and you're not having periods because your lining is not being built, we give you estrogen back, you're going to build a lining. If you don't have a progesterone along with that and you have a uterus, we have to give you both, because what can happen is you can get something called uterine hyperplasia, which can lead to cancers later on. Now, I can't tell you there's a clinician out there that would provide an estrogen without a progesterone if you have a uterus, but I just wanted to mention that just for education purposes, that in case you didn't know why are some people just on estrogen and some on both? That's why. If you don't have a uterus, you had a hysterectomy, well, then we don't have that issue with that lining getting built up. So it's solely estrogen. We have patches here. So we've got estrogen, progesterone combination patches you can use. Transdermally is the safest way to do hormone replacement therapy, but we also, it's individualized. So we also have oral regimens as well. So we have, like I said, combined patches, just estrogen patches. We have oral progesterone pills and so forth. In some cases, we use the progesterone, we use an IUD to help with that. So again, it's very individualized, but we do have the hormone replacement therapy for you. Next slide. Contraindications. So breast cancer in most cases is a contraindication. History of a pulmonary embolism or a blood clot in your lung or a DVT or blood clot in your leg. Those are contraindications for hormone therapy. Coronary artery disease, coronary heart disease. We don't want to increase that risk by giving you hormone replacement therapy, so that is a no. If you had a history of a stroke or a heart attack, we can't give hormone replacement therapy. Active liver disease, and then any unexplained vaginal bleeding, we'd want to work that up. It doesn't mean it's always contraindicated, but we have to work that up first. Next slide. So what are some of the benefits of hormone replacement? Remember, we talked about that osteoporosis, osteopenia. You add some of that estrogen back in. Again, we're not giving you therapy for bone loss. It's not indicated for this reason, but it happens to help us. It happens to build that bone back up or prevent more bone loss. So that is one, for those who can take hormone replacement therapy, that is a really good bonus there. And the rest of these sentences here, they talk about the possibility. I will tell you, there are a lot of research studies that were done 20 years ago that had some issues. We found some data, and then we found some data that we weren't sure was completely correct. So they're working on a lot of research now. So what I can tell you is there's a possible reduction in heart disease, a possible reduction in breast cancer in those who take estrogen only. And I did see that there are a lot more studies that are working on prevention of type 2 diabetes with estrogen therapy. So I'll caveat it though with, if you already have heart disease and you're 65, you're 70, you are 15 years from when you went through menopause, these things would not be accurate. It's really talking about those who have started HRT within 10 years of when menopause occurred. So, 48-year-old, 52-year-old, 55-year-old, sometimes into the 60s, it depends. But research is finding those tend to be the safest avenues. Um, and they're finding it's because we are less ill, typically, or less cardiovascular disease, less breast cancer rates generally. So typically we want to get HRT started, in the perimenopausal or early menopausal phase tends to be where you start to see these statistics and where things are looking a little more promising. Next slide. And I just talked about this, they call it the timing hypothesis. So estrogen, if given early and we don't have any coronary heart disease, things like that, estrogen may have a positive effect on our vasculature. And contrary, if it's damaged already, lots of different medical conditions going on, high cholesterol, lots of things that could damage that endothelium or the vascularity there, but it may have a negative effect. They're working on the research with that now. So yes, decreased risk would begun at menopause, may increase risk if we're started, like I said, 65, 70-year-old ages, things like that. Next slide. And this is just a quote from the North American Menopausal Society, and it just kind of puts things into context. The attributable risk of breast cancer in women on estrogen progesterone therapy is slightly greater than that observed with 1 daily glass of wine, less than with 2 daily glasses, and similar to the risks reported with obesity, low physical activity, and other medications. So you always, with medicines, have to look at the risk benefit ratio. So every medicine has a risk, every medicine has a benefit. And so this just was a good quote to just outline kind of what we mean. There is an increased risk for certain things, but quality of life too is an important factor here. Next slide. What can we do? What are some lifestyle modifications? Again, here at the VA, we revolve everything around this basis. So obviously, a healthy diet rich in fruits and vegetables. We have the MOVE program here. A lot of you probably have heard of that. You get a nutritionist. You've got the whole health team to talk about healthy living, exercise, all of those things. We're going to talk to you from a provider standpoint as well, but we have tons of resources here. Also, quitting smoking is very, very important, and we have help with that. We've got counselors here for that as well. As women, we should not exceed more than 1 alcoholic drink per day. So anything over that, we start to see kind of that tipping of health risk factors. Supplementing with calcium. So rule of thumb, you want about 1,200 milligrams of calcium, but you want to get about 600 of that from food. There's a lot of calcium sources out there in food, and you want to get 600 from a supplement. If we give it all in a supplement, studies have shown there's some cardiovascular risk there. So 600 from food, 600 from a supplement. Vitamin D, very, very hard to get from food sources and other. So 2,000 international units per day. You'll see in your multivitamins, there's 600, 800. I used to work in rheumatology, and so and I was a certified clinical densitometrist, and so we were giving at least 2,000 international units a day. That's sort of standard in what I give because everybody that comes in here is really low in vitamin D. And vitamin D provides a lot of things that your body needs to function. Next slide. We need to increase our fiber. We talk about that a lot in most of my visits throughout the day. Lots of healthy fruits and vegetables. We want to increase our omega-3s or our fatty fish. Those are really, really healthy for us. Foods rich in antioxidants. These are all things you already are aware of. Magnesium can really help be beneficial in a lot of ways. Protein. So to calculate that out, so basically a 170-pound person, for example, you need about 100 grams of protein. And then turmeric is just, as we know, a good anti-inflammatory to do. And then next slide, please. And these are just interesting facts. Vitamin D actually helps reduce our triglycerides. When we're estrogen depleted, we can decrease our good cholesterol or our HDL, and we increase the bad cholesterol, LDL, and the triglycerides. The fatty fish, the omega-3s, that helps decrease our coronary artery disease. And then fibromyalgia, which a lot of us women deal with, we're finding in research, and again, it's newer research, but that fibromyalgia might also be, along with the muscle aches and joint pain, could be partially due to estrogen depletion there. Next slide. And I think I failed to mention real quick in regards to exercise, and I'm going to recommend this to every patient, whether you're 20 or 30, but as we start getting into losing that estrogen in our 40s, 50s, 60s, and with that bone loss, we want to add in a lot more weight-bearing exercise. So lifting weights, you can do squats and push-ups and things at home, but that helps to keep our bone density a little bit better. And along with the muscle loss from losing that estrogen, really, really important that we do really good exercise. And I mean, cardiovascular and walking and all of that is also really, really good, but really incorporate that weight training as well. A lot of new research on that too. That concludes kind of my mini, real quick series on menopause, just kind of the basics, but reach out to me if you ever have any questions or come see me in the office.
Okay, and I'm going to leave the contact information up for a little while. So that way, those who are watching or attending, that you will be able to write down this information and make contact as far as with the Women's Health Center. I do have a question from Dolores. And that question is, what kind of hormone therapy can I get at the VA?
Go ahead.
Okay. So the hormone therapy that you can get at the VA, it's all of the FDA approved, which are bioidentical. So we've got some synthetic and some bioidentical. So that bioidentical word is kind of thrown out there with some of the, compounded pharmacies and things like that. We do have bioidentical hormone replacement therapy here. So we have the estradiol, we have the prometrium, we have the bioidentical hormones. So any of the estrogens, progesterones, we can get that here at the VA.
Okay. I have another question, and that is from Jolene. Jolene wants to know, will the VA pay for herbal supplements?
So unfortunately, generally speaking, the VA does not pay for herbal supplements only because they are not typically FDA approved, and therefore it's not something that the VA is able to cover, and they're usually purchased over the counter. So generally speaking, for those herbal supplements, you would have to purchase those on your own.
Okay. And here's Denise. Denise has a question, and that's how long can someone be on hormone therapy?
That's a very good question. So the research tells us that we should give the lowest dosage that works for the patient for the shortest amount of time. So 5 years is kind of one of those pieces that we try to aim for about 5 years. Are there people on less than 5 years and a little more than 5 years? Yes. But for the safety of them, as years go by, the risk goes up. So at 4 years, 5 years, 6 years, you're seeing a little bit increase in some of those risk factors we talked about.
Okay. And Deborah has a question. When should I get a bone density scan to screen for osteoporosis?
Okay, I'll take that one. So that's another great question. So the guidelines recommend that all women start screening for osteoporosis at the age of 65 with the bone density scan, which again, we are able to do here at the VA. There are some women who may need to screen a little earlier, depending on if they have risk factors. For example, if they had multiple fractures that, you know, a person wouldn't normally get, or if they've been on radiation therapy or have been on a lot of immune suppressants, things like that. But generally speaking, all women should screen at the age of 65, if not sooner.
Okay. And Evelyn has a question. Will hormone therapy help with bladder symptoms?
Absolutely. Typically, anyway, because we talked about how that the estrogen really affects the vagina, the urinary system. People can feel like they have a bladder infection, and they may not actually have a bladder infection. They just have urinary frequency, different things going on. And usually what we see, what Nicole and I see, is a decrease in those bladder symptoms. Once we rule out everything, once we rule out everything else, the estrogen does seem to help that tremendously.
Okay. Rose wants to know that she sees an OB/GYN doctor in the community for her hormone therapy. Will the VA pay for this?
Well, generally speaking, the VA doesn't pay for community care if we have it in-house at the VA. And because we are able to provide treatment for menopause and, well woman exams and all of that stuff, generally speaking, the VA would not pay for that for somebody to be seen by a community provider, because we do provide that in-house.
That's all the questions that I have right now. Are there any other questions? I do have one question that's regarding how do I how do I enroll in the women's clinic? And that's by Shauna. That is, you have to be enrolled in the VA healthcare. And how you would do that, Shauna, is you would be able to, if you are within the Dayton area, you can come to the hospital, come to our eligibility and enrollment desk, and they would be able to assist you as far as enrolling in VA healthcare. If not, you can also go to va.gov, and there is the enrollment button there that would take you there. And if you would like to call in, you can call 937-268-6511 and extension 2035, and we will send you out an enrollment packet as well. Okay, I will be putting up some slides for enrollment, how you can also contact our C box in order to enroll in VA healthcare also. Okay. Does anyone else have any questions out there for our subject matter experts? Okay. Ladies, it seems that this is going towards the end of our webinar. But if you have questions later on, I'm going to put up the contact information again, so that way you can call in or email our subject matter experts. Just one moment, please. And here it goes once again.
Also, if I could just make a comment, some of the websites on there are really good resources for women veterans. They're the first two are the national VA websites. There's a lot of good information about healthcare for women veterans that you can access. That third website, the mymenoplan.org, is a really good resource if you're having certain menopausal symptoms and you're wondering, okay, what could be good for it? Maybe you forgot everything that you just heard at the webinar or something. That's you can sort of personalize your own plan with that website. And also the next item, the Women Veterans Call Center, that's a national call center. If you have any questions about healthcare for women veterans in the VA, they can answer a lot of your questions. If you're having particular concerns and you're in the Dayton and catchment area, then they can refer those to me because I'm the Women Veterans Program Manager.
Okay. And with that, this has been an honor for having you on, and for everyone that's tuned in to our webinars. We appreciate your service, and we look forward to serving you.